A very warm good evening to all the respected ophthalmologists present here. Today I am here to present a case of uveitis masquerade syndrome in adenocarcinoma of lung. As we all know, uveitis masquerade syndrome can occur due to multiple malignant as well as non-malignant causes. We report a rare presentation of bilateral and multifocal choroidal metastasis from a primary adenocarcinoma of the lung with left eye pseudouveitis and neovascular glaucoma. A 43-year-old woman, she presented with painless diminution of vision in her left eye for the past 1 month. There was no history of any systemic illness, and medical history revealed anorexia and loss of weight for the past 6 months, for which no treatment was sought. On examination, right eye she had a best corrected visual acuity of 20 by 20 and an intraocular pressure of 12 millimeters of mercury. Anterior segment examination was within normal limits, and fundus examination showed multiple yellow colored elevated subretinal lesions. Left eye had a best corrected visual acuity of 20 by 100. Intraocular pressure was 26 millimeters of mercury, and anterior segment showed pigmented hypopyon, keratic precipitates, and fine neovascularization of iris. Fundus examination revealed dense vitritis with an inferior retinal detachment. Ultrasonography of the left eye revealed multiple dot echoes in the vitreous with multiple elevations of the choroid with moderate to high internal echo structure suggestive of vitritis and uveal metastasis. Also noted was an inferior retinal detachment. A thorough uveitic workup was done. All the investigations were within normal limits except for HRCT chest, which showed a lesion which is suspicious of malignancy. So all these features they proposed to an underlying malignancy with a distant metastasis, and the patient was referred to a surgical oncology team, and systemic workup was done. 18 FDG PET revealed an FDG avid lesion in the right lung upper lobe, metabolically active mediastinal, cervical, abdominopelvic, and bilateral inguinal lymph nodes, and multiple enhancing lesions were noted in bilateral cerebral hemispheres as well as in the liver. Left lung biopsy was done, and histopathology revealed tumor cells having pleomorphic, hyperchromatic, round to oval nuclei arranged in poorly formed glandular pattern with surrounding lymphoplasmacytic infiltration suggestive of a non-small cell carcinoma. And these tumor cells were positive for thyroid transcription factor 1 and negative for P450 suggestive of adenocarcinoma. And the patient was diagnosed as bilateral and multifocal choroidal metastasis from primary adenocarcinoma of lung, which was stage 4 with left eye pseudouveitis and neovascular glaucoma. And the patient was started on palliative chemotherapy with pemetrexed and carboplatin along with palliative radiotherapy for the brain mets. However, 4 months later, the patient succumbed to the disease. Uveitis masquerade syndrome are a group of ocular disorders that mimic chronic uveitis, and the malignant causes for this includes primary intraocular lymphomas, leukemia, uveal melanoma, retinoblastoma, metastatic tumors, and paraneoplastic syndromes that may mimic uveitis. In the eye, choroid is the most common site for metastasis owing to its rich vascularity, and the vast majority of ocular metastasis originate from the breast or lung, nearly 44% of the lung cancers present as ocular metastasis. Histologically, adenocarcinoma of the lung has shown high frequent choroidal metastasis followed by small cell carcinoma, squamous cell carcinoma, large cell carcinoma, and carcinoid tumor. All the previous studies have shown that choroidal metastasis from the lung cancer are most commonly unilateral and unifocal, as seen in 82% and 77% of the cases respectively. However, in our case, the involvement was bilateral and multifocal. Pseudouveitis has also been reported in cases of disseminated lung cancer, where vitritis can be due to seeding of vitreous by malignant cells or due to a paraneoplastic process. The paraneoplastic vitritis happens due to the production of antibodies against the tumor cells that cross-react with the host antigens. Glaucoma secondary to intraocular tumors has been reported in 5% of cases, and neovascularization of angle as a cause of glaucoma in uveal metastasis, that too due to lung cancer, has been very rarely reported. In this case, the long-standing retinal detachment could have induced iris neovascularization and secondary glaucoma. I would like to conclude that malignancy can present with atypical or refractory uveitis, making it important for both the ophthalmologist as well as the physicians to consider this possibility, especially in cases where uveitis does not respond to the conventional treatment. And this case highlights the need to maintain a high index of suspicion for malignancy as a potential cause of uveitis, because early detection and treatment can significantly impact the patient's prognosis. These are my references, and thank you for the opportunity.
So how was the response after starting the chemotherapy? Did you see the regression of the tumor size?
The patient was started with chemotherapy, ma'am. After 1 month of starting the chemotherapy itself, the patient she passed away. Since it was a stage 4 lung cancer with multiple metastasis, there was no response to the treatment.
It's a typical masquerade. What was little atypical was that B scan showed a pretty solid tumor, but at least on the B scan we couldn't see a retinal detachment. Usually if there is a secondary and mets, the retinal detachment is usually very big. Compared to this, it's a very small size of mass and a very large retinal detachment. In your B scan, the mass looked pretty large, but we couldn't, at least on the B scan, see a good retinal detachment, one thing.
Maybe due to the long-standing detachment.
Or maybe the probe position was different.
So what were the clinical features that made you think in terms of malignancy?
Or was it just because of the CT report that you got?
All the uveitic workup we did, ma'am, and everything came normal except HRCT.
No, the question is, did
Any
you
clinical-
work it up as a regular uveitis, or the moment you saw, you thought this could be a masquerade? That is her question.
And after seeing the like B scan and all those things, and when we again went back and we asked her like any loss of appetite or anorexia, all this when we asked, the patient told yes, I have all those.
So the patient had systemic
6 months she had
features also.
features also, ma'am.
So it's important to maintain a high suspicion, keep it suspicious, and you should actually work up in terms of that. In fact, nowadays people are coming at a very young age also with such kind of a picture. So it's not only the older patients that you need to work up for malignancies. Yes.
Sure.
Thank you.